I think we had a very exhaustive talk on systolic function by Dr. Tipu, and since morning we have been having the different aspects of heart failure, for example, from diagnosis to the management in heart failure with reduced ejection fraction with Dr. Tahira. Then I think with the multimodality imaging from Professor Jaron Bax, which was excellent, and finally, and then we had the CRT used in patients with heart failure, and Dr. Tipu giving an excellent talk on heart failure with systolic, how you would evaluate a systolic dysfunction. Now, when we talk about heart failure, remember that we have 50% of the patients who have heart failure with a preserved ejection fraction, as they have an ejection fraction of 50% or higher at diagnosis, and it affects nearly 32 million people worldwide. By the year 2030, it is going to be 64 million. So you can imagine the extent of the problem that we are facing. So we need to actually, and the diagnosis of these patients is extremely difficult. Like Tipu said about the strain imaging in heart failure with preserved ejection fraction, where you have typical patterns with amyloidosis, sarcoidosis, hypertrophic cardiomyopathy, valvular heart disease, coronary artery disease, where you can make some evaluation in these patients. Now, when we look at heart failure therapy, what we need to see is that we have heart failure with preserved ejection fraction, with an ejection fraction of 50%, and symptoms of heart failure and evidence of elevated filling pressures. This is important. And how we calculate these elevated filling pressures, we can see that clinically, and we can see that on echocardiography at rest or with exercise. And I think it is important that when we are doing echo, patient comes to us with dyspnea, and what we find is that everything is normal, but the symptoms are there. Then I think that you need to put the patient through a little stress, like for example, you can raise the legs or give a hand grip, and you will find that the diastolic dysfunction will be becoming worse and then also the filling pressures will become worse in these patients. Then we treat as heart failure with preserved ejection fraction, and this is the treatment that we have in these patients. Then you have the second category, heart failure with mildly reduced ejection fraction, when you have the ejection fraction from 40 to 50%, 49%. 50% and above is preserved ejection fraction. And then you have ejection fraction which is less than 40%. There the patients have symptoms of heart failure, or they may be asymptomatic as well. It is, as I said earlier on, it is an extremely common cause of exercise intolerance linked to obesity and sedentary behavior. Remember this. And despite the advances in understanding of pathophysiological mechanisms, which I'll show to you, diagnosis and treatment, it still remains under-recognized. And that is what we need to keep in mind. We need to have a high index of suspicion to diagnose heart failure with preserved ejection fraction. Whenever a patient comes to us with obesity, with dyspnea, and you find that the ejection fraction is normal, you even do a strain imaging and that is normal, do not think that the symptoms are not correct or the patient is not dyspneic. Perhaps then you need to stress the patient and you'll find what the answer is. Further research is needed to characterize heart failure with preserved ejection fraction phenotypes to promote individualized management and to improve the outcomes in these patients. Now, when we look at the pathophysiologic paradigms in heart failure with preserved ejection fraction, uh, and they have arterial hypertension, left ventricular hypertrophy and fibrosis. Then there is left atrial dilatation, left ventricular dilatation or hypertrophy, heart failure with preserved ejection fraction, post-capillary pulmonary hypertension, and as a result, there is a remodeling of the right ventricle and right atrial remodeling and dysfunction. So this is the pathophysiology which you understand in patients with hypertension, arterial hypertension causing all these changes here. Then, but there are other mechanisms also, like for example, you can have a pro-inflammatory comorbidities, but the various factors which then result in cardiac dysfunction at rest or with exercise and resulting in heart failure with preserved ejection fraction, pulmonary hypertension, pulmonary vascular, right ventricle and right atrial modeling and dysfunction. Despite this understanding, the treatment in these cases, when you are putting them on anti-inflammatory drugs like, for example, colchicine, they have not shown any benefit in these patients. Then you can have multiple risk factor permutations as the basis of the heart failure with preserved ejection fraction, and you can characterize it according to the pathophysiological mechanisms, which can then you can give a specific therapy in these patients with heart failure with preserved ejection fraction. How will you diagnose these patients? That is extremely important. And I think Tipu talked about echocardiography, heart failure symptoms and risk factors for heart failure with preserved ejection fraction, which present, for example, you have obesity, older age, hypertension, and diabetes. Then echocardiography will give you the ejection fraction. And we go a step further and do strain imaging in these patients. And then we can say, if everything is all right, then we need to look at the non-cardiac conditions like lung disease, anemia, deconditioning, or additional multifactorial dyspnea in these patients. And we need to identify specific treatable conditions that can cause heart failure symptoms. Earlier on, as Brigadier Asif talked about, when we do a clinical assessment, we need to look at the history of these patients. And then the NYHA cluster, you can either have an overt congestion or unexplained dyspnea in your patients. In overt congestion, you will have patients with a history of NYHA 3 or 4 symptoms, paroxysmal nocturnal dyspnea, orthopnea, dyspnea when you are bending. This is also important, which is bendopnea. So this can be a symptom for patients with heart failure with preserved ejection fraction. We look at the physical examination. The JVP is raised. There are RALs, edema, ascites, and obesity are common. On this side, you will perhaps the unexplained dyspnea, you may not be able to get congestion in these patients. Then the electrocardiogram will give you left atrial enlargement, left ventricular hypertrophy, and usually normal when there is unexplained dyspnea in these patients and when there's no congestion. Chest X-ray, cardiomegaly, pulmonary congestion, again normal. Then the echo findings, an elevated E by E prime, which gives you the pulmonary capillary wedge pressure, which gives you the left ventricular filling pressure. So this is what you need to see in these patients. Pulmonary hypertension. Left atrial enlargement is extremely important. And remember that it is not the measurement that you are going to take on a long axis. It is the left atrial volume index which you need to calculate. in your patients, and that will give you an idea as to what is happening in your patients. As regards the BNP or NT-proBNP, there are several situations where the abnormalities may not be there, or the abnormalities are there. For example, the false positive in older age, in female sex, in those who have atrial fibrillation. So these conditions can give rise to false positive results with NT-proBNP and BNP. Remember that. You need to have some calculations where you can then make some assessment about the left ventricular the heart failure with preserved ejection fraction. For example, the clinical variable, if the BMI is high, it's a 0.2, you score 2 points. Hypertensive, 1 point. Fibrillation, 3 points. So as the scores increase, chances of heart failure with preserved ejection fraction are there. So I think we must keep in mind the H2F pEF score by which we can diagnose our patients with heart failure with preserved ejection fraction. This is the suggested algorithm for establishing the diagnosis: unexplained dyspnea or dyspnea out of proportion to comorbidities. Have a high index of suspicion. Then you have a more specific cardiac diagnosis. This is what was talked to you earlier on: pericardial disease, infiltrative cardiac disorders like amyloidosis, sarcoidosis, hypertrophic cardiomyopathy, valvular heart disease, RV failure. Then if there are specific conditions, yes, you treat that condition. If no, is there an evidence of congestion? Then you look at all these things like abnormal examinations, etc. If this is also a negative probability of heart failure with preserved ejection fraction, then you look at the typical demographics in your patients. Then the typical echo features that you can find. Probability of heart failure with preserved ejection fraction, if it is high, then the diagnosis is there. So you need to see if there are comorbidities. Look at the echo. There are many features in the echo which will give you this idea. These are the different scores that you can have, as I talked about earlier. What is the differential diagnosis? You have a patient with heart failure signs and symptoms of normal LVF, pericardial disease, constrictive pericarditis, constrictive effusive disease, post-pericardiotomy syndrome. Like, for example, post-CABG, you can have circle indicates all clinical heart failure with ejection fraction more than 50%. And you have the different phenotypes: obese, cardiometabolic, heart failure with preserved ejection fraction, ischemic, LA myopathy. As the left atrium dilates, it becomes myopathic. That is why they develop atrial fibrillation. Now, when we look at the different randomized, we are coming to the management of heart failure with preserved ejection fraction after we have diagnosed it. So we've heard about these trials from Dr. Tahira in the morning. Now, these are the patients with heart failure and LVEF more than 40%. It's a busy slide, but I'll take you through it. The different trials that we have had in heart failure with preserved ejection fraction: CHARM preserved, pEF heart failure. All these trials, right up till this Paragon heart failure, were neutral trials, where you used MRAs and you used other drugs like Candesart and ARB. They were neutral. But here in Paragon, it was borderline favorable. For example, in female patients and in those with an ejection fraction between 40 to 55%, there is a benefit when you use these drugs. With Emperor preserved, it was a positive trial. Deliver was a positive trial, and you had the benefit of nearly 20% reduction in heart failure hospitalization and cardiovascular death in these patients. And that actually gives an indication that there is a 1A indication of SGLT2 inhibitors in your patients with heart failure with preserved ejection fraction. And that is why today we have a treatment for it. We did not have it before this. So how are we going to manage our patients? We need to control hypertension. It should not be suboptimally controlled. We should control it at the level which the blood pressure where there is no progression to left ventricular hypertrophy or fibrosis. We need to treat diabetes, prioritize SGLT2 inhibitors as in all patients, ACE inhibitors or ARBs. And now we have a new kid on the block as far as MRAs are concerned. We have finerenone for ongoing proteinuria despite ACE inhibitors. Obesity, we need to reduce the weight. Aerobic training, we must manage the weight daily so that we can understand that there is a progress in the management of your patients. When there is chronic kidney disease, we have ACE inhibitors or ARBs for proteinuria, SGLT2 inhibitors, finerenone, if diabetes and ongoing proteinuria despite ACE inhibitor and ARB. When we're talking about coronary artery disease, antiplatelet therapy, moderate high-intensity statin in our patients, revascularization, atrial fibrillation, they will need anticoagulation. And those who are, there's an inappropriate response of heart rate to exercise, avoid routine use of beta blockers in absence of compelling indication. So this is the management of key non-cardiac and cardiac morbidities, comorbidities in heart patients with preserved ejection fraction. So what is strongly recommended? SGLT2 inhibitors, self-care plan education, aerobic exercise, diet-induced weight loss plus aerobic exercise for patients with obesity, loop diuretics for patients with fluid overload. So you decongest your patients. Manage hypertension according to the guidelines. For atrial fibrillation, according to the atrial fibrillation guidelines, may be considered MRAs, angiotensin receptor and neprilysin inhibitors. We talked about sacubitril valsartan, angiotensin receptor blocker such as candesartan, and then we need to manage according to the pulmonary artery pressure-guided therapy. Nowadays, there is a new concept of creating an intra-atrial shunt in your patients with heart failure with preserved ejection fraction to reduce the left ventricular filling pressures. So what are potentially harmful in your patients? Nitrates, sildenafil and soluble guanylate cyclase stimulators in patients with heart failure with preserved ejection fraction, rate adaptive atrial pacing in patients with preserved ejection fraction and heart failure, and chronotropic incompetence. This is the suggested algorithm. Confirm the diagnosis, give diuretics for congestion, then for ejection fraction more than 50%, you exclude the masqueraders. The masqueraders are amyloidosis, hypertrophic cardiomyopathy, coronary artery disease, sarcoidosis, valvular heart disease. And then you come to the guideline-directed therapy as indicated here. Exercise for all patients. This is the important fifth pillar in the management of your patients with heart failure. SGLT2 inhibitors, all eligible patients. Then ARNI in selected patients, 50% to 60% ejection fraction. MRAs, again 50% to 60%, and diuretic agents as needed. So this is the algorithm that you have to follow in your patients with heart failure with preserved ejection fraction. This is the same repeated again, and I'll come to the last slide. The conclusions are effective pharmacological therapy is now available to modify disease progression in heart failure with preserved ejection fraction. And we should go according to the guidelines. After confirming the diagnosis and excluding alternatives, clinicians should aggressively manage congestion, address comorbidities, and initiate evidence-based medical therapy. SGLT2 inhibitors are appropriate for most patients. Use them. ARNI, appropriate for many. Use it. I think give your patients the benefit of guideline-directed therapy. And remember, exercise and physical and lifestyle modification to facilitate weight reduction are appropriate for all patients. It is extremely important to tell your patients to take the weight every day and don't let the weight go up. This will show that there is no congestion in your patients. And I propose, and I think it will be accepted, the 5 pillars for the treatment of heart failure with reserved ejection fraction. Exercise all patients. SGLT2 for all patients who are eligible. Who are not eligible with severe eGFR reduction, they are not eligible. Ketoacidosis, they are not eligible. Diabetes type 1, not eligible. Then ARNI and ACE inhibitors selected patients for ejection fraction of 50 to 60%. And then you have MRAs, same ejection fraction, and above all, diuretic whenever it is needed. These are the 5 pillars of heart failure with preserved ejection fraction treatment. Employ them in your patients and have a high suspicion of index of suspicion so you can diagnose these patients. Thank you very much.